So our first panel is with some very important people in Atlanta and in the world. I would like to invite up Dr. Grace Gombolay, Dr. Spencer Hutto, Dr. Douglas Stuart, and Dr. Mitzi Joy Williams. All right. Please join me in welcoming these fabulous panelists. There's a round of applause. Okay. Why don't we start with some introductions? We'll start with you, Dr. Stuart.
I don't know if this one. Yeah, so I'm Doug Stewart. I'm the oldest guy on the panel here. You know, whenever you have a panel, you have to have at least one old codger.
No white hair, though.
I got a few. You have to have somebody who can remind everybody what this was like before we knew what NMO was, and certainly before we knew what MOGAD was. And I'm one of those guys. So I'm the old geezer that used to get it wrong before we had testing that allowed us to do this. I've been practicing in Atlanta since 1993. I trained in Chicago. My father was a neurologist, so I came by this sort of honestly. And we practice in Buckhead, and we have seen quite a lot of patients come through, and it's been one of the most sort of encouraging developments in my practice career to see how we've been able to redirect the path of treatment. So,
absolutely, thank you, Sven.
Okay, welcome everybody to Emory. My name is Spencer Hutto. I'm an autoimmune neurologist by training. I do work a lot in the hospital. And so a large part of my experience working with NMO and MOGAD patients are actually during their first journeys in the illness. And so I meet a lot of people when they present with symptoms before they're diagnosed. And so it's been very interesting to work with them in that setting as they kind of navigate the first steps in their journey. Welcome to Emory. I'm glad everybody could be here and have this opportunity. And just want to say thank you to Samira and her foundation for coming and for bringing us all together and giving us a chance to, to realize what resources are available locally in our community, but also online, and just the amazing work the foundation is doing and sponsoring research on the order of $1 million, so far is quite impressive. So welcome, and I'm looking forward to the discussions today.
And you're a through and through Georgian, right?
I am. I was born in South Georgia, and so I do know what it feels like to be, or to experience difficulties, I guess, with getting the very best care. So my family, it's sort of routine to travel, 3.5, 4 hours to Atlanta to get, just the care that you needed. And so I know a lot about, what that feels like to some degree. So, but I am born, raised here. I did my residency here actually at Emory, and I spent a year in Boston, Samira's home, working at Mass General, and also getting to meet Michael Levy and some of the other fine folks up there. So, but I came back.
Thanks for being here.
Hi, everyone. I'm Grace Gombolay. I'm actually a pediatric neurologist who specializes in neuroinflammatory disorders. Born and raised in Texas, went to school at Hopkins for both undergrad and medical school, and then made my way up to Boston for residency, including fellowship training at Boston Children's Hospital and Mass General and the Brigham. Came down here just about the fall of 2018. My husband's family is here, and we had a baby at the time, but I really saw the opportunity and need because there wasn't really a pediatric neuroimmunology specialist here. The closest areas were Alabama and North Carolina, but there weren't a lot of people in the area. So I really saw this as a wonderful opportunity. And since being here for almost 6 years now, coming this fall, we've now seen almost 400 children with rare neuroinflammatory disorders. I have so many patients with MOGAD, NMOSD, MS, autoimmune encephalitis, even the seronegative who don't quite fit in certain buckets quite yet. And so it's been really a privilege to be part of that. I have a wonderful team who is back in the corner over here, including our first fellow, our program coordinator, and Dr. Conan, who's one of my other colleagues. You'll hear some from them, but I'm really grateful to be here. And so thanks for having us.
All right, last but not least, I'm Mitzi Williams. Good morning, afternoon, everybody. Thank you, Samira, for inviting me. I am also the nerdy neurologist for those that are on social media. I am probably the second oldest person on the panel, and I dye my gray hair, so unlike Dr. Stewart, you can't see mine. But very excited to be here and have a discussion. Also trained in Atlanta. I was born in Chicago, but pretty much grew up here, went to Emory for undergrad, and then went over to Morehouse School of Medicine for residency, for medical school, and then down to Augusta, to the Medical College of Georgia, and did residency and fellowship. And I treat primarily MS and NMOSD and MOGAD. So very excited about the conversation, and glad to be here with you guys today.
Mitzi also has a Sumaira in her life in addition to me.
I do.
crazy is
Yeah.
that?
So my right brain, with my left hand, my other right, is Sumaira, who is my admin. And so whenever we are all together, everybody's turning their head when I say Sumaira. Yeah, it's a Sumaira sandwich.
Well, thank you all for being here. So I will ask each of you questions, and then I would like to leave some time for the audience to ask questions too. But we're just going to cover some basics and then work our way deeper. So, Mitzi, let's start with you. Can you please briefly share the 2024 definitions of NMOSD and MOGAD?
Yeah. So NMOSD. Is an autoimmune. So NMOSD versus MOGAD really has to do with, now we have antibodies that can help us to test for these diseases. As Dr. Stuart was saying earlier on, we did not have those available. And the symptoms are a little bit different. So with NMOSD, we primarily think of optic neuritis as well as spinal cord disease. We look at the length of spinal cord lesions with NMOSD, and there can be brain involvement as well with NMOSD, which traditionally, when it was considered a part of MS, we didn't think of it as having brain involvement. So, our understanding has really evolved over time, and MOGAD also has optic neuritis and spinal cord involvement, but does have a positive antibody for that.
Perfect segue. Dr. Stuart, can you please educate all of us in the most patient-friendly way about the aquaporin 4 antibody and the MOG antibody?
Sure. So, as I said early in my career, we were what doctors call lumpers, and so we knew that there were these conditions, NMO, which was optic neuritis and spinal cord disease without any brain disease, but we just all thought it was some variant on MS. In 2004, the aquaporin antibody, the NMO antibody, was discovered, and it really kind of changed everything. Although I must say it took some time for the community to accept that this was really something. But we had known that this certain subgroup of patients just didn't respond well. You would give them everything possible for MS, and they didn't react like an MS patient should. So they discovered that there was an antibody to astrocytes, which is not the target of multiple sclerosis, and the majority of patients with these refractory conditions that we thought were MS but weren't MS have this antibody. So that's the aquaporin antibody, the NMO antibody, and for the majority of patients with NMO, they will have an antibody, especially now that they've improved the way that you do this with something called a cell-based assay, and really no one should do it any other way. It's just so much better. It was in, I think, 2015 that the MOG antibody was discovered because we had patients who had what appeared to be NMO, but they weren't testing positive for the NMO antibody. And so, we said, well, you got seronegative NMO, but it turns out once we discovered this antibody, we started to pull some of those patients out of the NMO family. So we've been able, I think, this is one of the victories of sort of laboratory medicine, is that we've taken the patients all lumped together and we've started to address specific diseases with specific therapies, and it's really changed everything, and it's completely transformed the prognosis for therapy in patients who have these specific antibodies. There is still a small group of patients who don't have an antibody for either one, and yet they have the clinical syndrome. But long answer to a short question, but that's where we are.
Just a quick poll. How many of you have MOGAD? Raise your hand. 1, 2, 3, 4. And of the 4 of you, how many were told you had NMO first and then you found out you had MOGAD? 1, 2. Yeah, okay. And you, yeah, that's pretty common. We hear this a lot. So having this commercially available test has been such a game changer, because now you know for sure that you have this antibody and you have a definitive diagnosis. Again, a perfect segue. You guys are easy panelists. Thank you so much for making my life so easy. Dr. Hutto, Can you please talk about seronegative? Seronegative.
Yeah, so this is a great question. I think we have two antibodies that we test for commonly in this scenario. Once we think a person is less likely to have multiple sclerosis, and of course those things are easier to send. It does take many times for us at least somewhere between 5 to 10 days to get the results back, and once those are negative, we start to form our opinions about the possibility that it could be seronegative. I think in these patients, what we are trying to figure out really from the get-go is do they fit the clinical phenotype or what we call the clinical radiographic phenotype for seronegative NMO. And what that means is a lot of these patients will have the same syndrome as the patients who have MOGAD and NMO, but their antibodies will be negative. So they may have optic neuritis, they may have transverse myelitis. We might meet people with area postrema syndrome who have nausea, vomiting, and frequent hiccups, but their testing is negative, but for all intents and purposes, they present with the same symptoms, and their MRIs look very similar to that. So nowadays, fortunately, we have a lot of great diagnostic guidelines in deciding, which patients look very similar from a clinical standpoint and a radiographic standpoint. And we do our best to look carefully at the MRIs to decide, is that fitting? And importantly, in this population, I also would emphasize that there are many disorders that can affect the optic nerve, and there are also many disorders that can affect the spinal cord that also may not be associated with an antibody. So I think in this group, we do a lot of testing, and so many of you actually may have experienced this regardless of if you're seronegative or not. And if you come to my hospital, you will probably be subjected to extensive testing to make sure that we really define your problem as accurately and as best as we can to put you on the very best treatment. But in this group in particular, we want to make sure that the testing is extremely thorough and that things match up, and then we may reach that definition of seronegative NMOSD after a pretty thorough workup and many days in the hospital.
To my seronegative buddy, let's talk offline after. I have some ideas. Okay, Dr. Grace, can you educate us about the latest in terms of prevalence and incidence and peds versus adults? Who does it affect? How does it manifest differently, if at all?
Yeah, that's also a great question. And this is one of the things I find very interesting about these diseases, because even though we know that there's the same antibody, for example, the aquaporin 4 antibody, or especially in MOG antibody associated or in the MOG antibody, it can actually look quite differently in children versus adults. So for example, in MOGAD or MOG antibody disease, younger children present with what's more commonly known as ADEM, acute disseminated encephalomyelitis. What that looks like is that they come in, they can have fevers, they may not, they look very sleepy, sometimes they have seizures with this. And when you look at their brain MRI, there's lots of big fluffy lesions on there. And so I've had definitely patients who were told they have ADEM, and then turns out later on that it was related to MOG antibodies. Whereas older adults are going to more likely fit what we call the classical NMO phenotype, where they're more likely to have the optic neuritis and the spinal cord symptoms or transverse myelitis. But I can say I have children who present with the optic neuritis, transverse myelitis phenotype, or the NMO, looking more like NMO. And there's definitely adults and older people who can also present with ADEM, but generally that's how it can look. But it's very interesting that it can look differently depending on your age, and how you respond to treatment can sometimes be different too. One of the other things to really know is that there's other MRI features that can help distinguish between MOGAD and NMOSD. So one of the things that we actually did a study through our institution at Children's Healthcare of Atlanta, where we looked at the MRIs of all patients who had suspected MOGAD versus NMO versus MS. And what we found was the MOGAD patient actually had this particular MRI finding called leptomeningeal enhancement. What that is that there's a special contrast. A lot of you who have had an MRI probably had this also, to see if there's any active inflammation going on during the scan. And what we found is that in kids, about 1/3 of patients with MOGAD will have this leptomeningeal enhancement, but patients with the aquaporin 4 NMOSD or MS actually do not. And so now we're starting to look at these MRI markers, and it's very similar actually in adults also. So Owen Flanagan at the Mayo Clinic actually looked at this in over 200 patients, some children, mostly adults, and found a very similar finding where a lot of the MOGAD patients do have this leptomeningeal enhancement, whereas the aquaporin 4 and MS do not. So even though there are some differences, there's some overlap between the kids and the adults.
What about demographics? Like, Asians versus Africans versus Caucasians?
Yeah, this is true for a lot of our inflammatory diseases, where it seems like these diseases disproportionately affect non-white, non-Caucasian, non-European background. There's lots of theories about that. There's lots of questions about it. And I think that's all the things that we're exploring. And especially depending on where you practice, also sort of sets up your patient demographics. But I can tell you here in Georgia, just because we do have a very diverse population compared to a lot of areas in the country, we do have a good proportion of patients who are identify as Black or Latinx, fewer Asian compared to the other two groups. But about 20% of my practice is actually predominantly Spanish speaking also. And so it's very interesting to see how the demographics can be different.
Dr. Williams, can you tell us what, for someone who's suspected to have either of these, what does the typical workup look like? So testing and imaging and all of that. And then for people like us who are diagnosed already, are there things that we should be getting tested regularly for, or imaging or whatever?
Yeah, so that's an excellent question. So when we think about the diagnostic workup, some people can be missed, right? And so, I think that, as has been described earlier and you talked about earlier, it's important to be diagnosed as early as possible. Unlike MS, we do not consider NMOSD and MOGAD as progressive diseases. So the majority of the damage that's done is when you have that attack. So it's really, really important for us to catch it early and prevent attacks as much as possible to prevent disability. So when someone, let's say, comes with a symptom of optic neuritis and they go to see the ophthalmologist and they suspect it may be they're diagnosed with optic neuritis, then they may then be referred to a neurologist. The common workup first starts with an MRI, an MRI of the brain, but particularly if we're thinking about NMOSD and MOGAD, we definitely want to image the spine because often we may not see very much involvement in the brain. And then depending on what those images look like, you may undergo other testing, including blood tests, right? So the antibody testing, if that's what we suspect. And then also I've had some patients where maybe they have a couple of lesions that are questionable and we're going between MS and MOGAD or NMOSD, and we also do a spinal tap or lumbar puncture. Now for multiple sclerosis, often because MRIs are so good now, the imaging is so good, we often don't do lumbar punctures. But if there's any question with the presentation or any concern with the antibody testing, then certainly a lumbar puncture would be appropriate. In terms of after someone is diagnosed, we just had a discussion about this the other day, actually, about whether people should have continuous MRI and imaging, and it may vary, from person to person. But certainly in the beginning, when someone is initially diagnosed, particularly if they have large lesions or things with inflammation, we may image, periodically. But certainly at the discretion of that neurologist, they may spread out the timing of the imaging because we just typically don't see that same silent and progressive disease that we see with multiple sclerosis.
Lovely. Thank you. Okay. So there are two R words that are very triggering for me in my life. Relax, when a man says it,
Or smile.
or smile, or relapse. Yikes. None of us want to. I hate the word relapse and everything that comes with it. So I'm going to give you the tough question.
Oh, great.
Yeah. Tell us about, of course, what is a relapse versus a pseudo-relapse? Because I'm sure many of you have also experienced pseudo-relapse. I have many a time. And in addition to being, on our therapies and on schedule and whatnot, is there anything that we can do as patients to avoid having a relapse?
Okay. Well, so this is a common question to our clinic because the patient doesn't know a relapse from a pseudo-relapse. So the patient just knows that on Monday they felt fine and on Tuesday they're numb again or they're weak again or the vision's blurry. Our nurses have been trained to ask a couple questions up front, and that is, do you have symptoms of a bladder infection? Do you have a fever? Are you exhausted? Is anything going on in your life that's knocking you off of your normal rhythm? A true relapse means that there is new damage. There's new inflammation that didn't exist previously, and now you've got either a new lesion or an old lesion has been flared up, and there's something going on with your immune system that's been turned on. A pseudo-relapse means that the scar that you had from before had recovered to a point where you could live with it and you barely noticed it, but if you get exhausted or overheated or you have a fever, it can take that functioning, sort of accommodated area of damage, and it can decompensate it so that you feel more symptoms and you feel like it's been reactivated, but it's not new inflammation. It's just that nerves like to work within a certain sort of limitation of body temperature and electrolytes and all the things that allow things to work perfectly. So that's the difference between a pseudo-relapse is not as dangerous because it's going to go away when you get some rest and your fever goes away, whereas our true relapse is new damage, and you have to take that seriously. We treat it with steroids typically and sometimes, quite a bit more aggressive medication.
Perfect.
And how do you prevent it? You did ask me, how do you prevent it? Well, so there's a lot of stuff that we don't spend enough time emphasizing. I think rest is something that in our culture, we feel like we've got this fear of missing out on everything, so we burn it at both ends. We're working all the time, and then we're playing all the time, and people don't give their body enough time to rest, number one. Number two, we don't exercise, we don't eat well. There are things that we don't work into our life to try to keep our body tuned. So I think those are the things you can do. You can't avoid catching a virus from somebody. You can't always avoid getting a bladder infection, but you can get some rest.
My generation calls what you just referred to as FOMO.
That's right.
Yeah. Okay.
So does my generation.
Oh, okay. Amazing. Okay, so on the topic of relapses, we'll keep the relapse conversation short. Dr. Hutto, what are some acute interventions for folks who are having a relapse, both with NMOSD and or MOGAD? Or MOGAD.
So I'm very happy to take this question as an inpatient neurologist. So I lucked out. I think this question well chosen. So when patients experience a relapse, I think the number one thing that I can try to instill upon everybody here is that it's extremely important to come to the hospital as quickly as possible. These are rare diseases, and so we don't have as many clinical trials as we would like to have to prove everything without a shadow of a doubt. But there are many studies now that examine retrospectively how well patients end up doing in reference to how quickly they come to the hospital and receive treatment. And so I would encourage you by saying to begin with that it's not necessarily your responsibility to know if the symptoms are related to an NMO or MOG attack. Just come on quickly into the hospital. Let us help determine whether or not it represents relapse, so that way we can start treatment as soon as possible. Generally speaking, when you come to the hospital, it will be probably similar along the lines to what you may have experienced originally, with the exception that you have a diagnosis, and so it's quickly apparent what medications need to be started quickly. But oftentimes, patients will be started on steroids, and so many of you probably have at least some experience with IV steroids, and we use that in the hospital. And generally, we determine how much we use based on the person's severity and how quickly or not they're responding to steroids. So it's common that we give patients steroids for 3 to 5 days and adjust that dosing based on how they do. And sometimes people will also go on to take some degree of oral steroids when they leave the hospital. The major thing that I really want to impress upon everyone, especially the patients who have NMO, is that there is a growing amount of literature to suggest that a treatment called plasmapheresis is very helpful in getting you back to where you were pre-attack. And how likely you are to go back to your pre-attack baseline has a lot to do with how quickly we get the plasmapheresis started. So you really help us out by coming in quickly from the moment that you feel you have symptoms. So that way, I actually tell all of our residents that a relapse of NMO is almost the same thing. It's the neuroinflammatory equivalent of stroke. We want to put in a VAS cath immediately in the ER and get the plasmapheresis started, almost by the time you're in the emergency room. And so some of you may have experienced what it's like to be treated with plasmapheresis, but it does entail removing your blood and essentially getting rid of the antibodies. So, these are largely antibody-driven processes. The plasmapheresis filters your blood and gets rid of the bad antibodies. It also gets rid of some other forms of inflammation that kind of accentuate damage related to the attack, so chemokines and cytokines. And we filter it. We give you back the cellular components of your blood and fresh plasma that doesn't contain the pathogenic antibody. And so usually people undergo 5 treatments. It's every other day. And that's generally speaking how we approach these disorders. I will say for our MOGAD patients, you're probably asking, well, what about me? Like, do I get plasmapheresis too? And there is beginning now some retrospective studies that are suggesting that plasmapheresis may be useful in our patients with MOGAD. And so here at Emory, looking back at our own experience, it is limited because it is a rare disorder, but we have some preliminary data to suggest that plasmapheresis is helpful to those patients with MOGAD experiencing attacks of acute optic neuritis. And so there is growing literature to suggest that it's also helpful in our MOGAD patients. Sometimes when we can't use plasmapheresis for whatever reason, and there can be a variety of reasons, we consider IVIG, particularly in our MOGAD patients. And so we have a variety of options available to us now. And just want you all to know that and also understand very clearly that come on into the hospital as quickly as possible.
What a nice doctor. There were some ER doctors I've encountered when I've had relapses who weren't so welcoming. So it's really nice to hear how encouraging that is. Dr. Gombolay, I know you believe in this because your practice is sort of set up this way. In your opinion, what is the most ideal multidisciplinary team for an NMOSD or MOGAD patient?
Yeah, absolutely. Happy to talk about this. And you're going to meet some of these folks later on different panels today. But the way that we've set up our practice, and this was very important to me. So I told you that when I started in 2018, there was no clinic here. And so we set up this program. And as part of the program, I was very clear with the leaders of our hospital saying that when a child or a patient has diagnosed with this, not only is it patient changing, it's family changing, life changing diagnosis and experience. And so we can't just treat the patient, we have to treat the whole family. So what's very important to me is that we have a psychologist. So we have a pediatric psychologist who is with me in the clinic to make sure that we're taking care of the mental health resources. She is especially there. I make sure, especially when there's the new diagnosis, how to manage that, how to cope with that, what are the things around that. She is there to help the families navigate that process. I also have Gwen, who is, I say, my right arm, my right leg, and both my legs and my arms, because she does all of the things to actually make it happen. She helps with infusions. She does all of the prior authorizations. She helps with anything when insurance comes back and they say, oh no, this has been denied. She first calls the families and says, don't worry, we're going to figure this out. And she has all of these letters set up. She has phone numbers. She knows people. And she has this set up. And she also works with families, and hopefully you'll hear more about this later on, of making sure that if you're getting a treatment like an infusion, where is it going to be done? So there's different places that you can get your infusion done, whether it's in the hospital, in an outpatient infusion facility or a clinic setting. But we also work with a lot of home infusion companies. And so she will ask the family, what works for you? And some families are saying, I feel more comfortable if I'm in a hospital setting. So that's my preference versus, oh, I want to be at home. And so when you come to the clinic, you're going to meet with our psychologist, Dr. Wright. You're going to meet with Gwen to make sure your treatments are going where they are. And in addition to that, we also have 3 neuropsychologists now who specializes in children who have these neuroinflammatory diseases. So they know what to look for. They know what challenges there are. We make sure that we talk about school, right? So a lot of my patients are still in school, and a lot of these schools have not, the teachers, the counselors, the principals, they have never heard of this before. And they say this, including to the MS patients, they say, well, you look fine. Like, what do you mean you need these extra resources and support? And so we really help the families navigate that process. We have additional members, including rehabilitation, physical therapy, occupational speech therapy, if we need them. And I also have a whole research team who is there with me in the clinic, because I've been very fortunate to be involved in research. We bank patient samples, and a lot of my patients who are here today are part of that. So thank you so much for contributing, because the idea and the goal is, yes, we have some phenomenal treatments. And so thank you to all the companies who have worked on this, but we're not there yet. We need better diagnostics. We need better prognostics predicting how patients are going to do. We need better ideas of is there a marker that we can identify saying, oh, you're going to do better on this treatment? And so that's a lot of the work we're doing in the lab. And so I have my research staff who helps me with all of the paperwork, with facilitating all the items that need to happen with patients, making sure the blood gets to the lab, that processing and storage, and all of those things. And so that's how we've set up our clinic.
Lucky patients, for sure. So there's a lot of work that still needs to be done in the world of NMOSD and MOGAD, but as a patient who's been living with this for the last 10 years and an advocate, what I have seen from my perspective over the last 10 years in terms of advancements is remarkable. It's almost miraculous in some ways. You know, as I said earlier, when I got diagnosed 10 years ago, there was no FDA-approved therapy. Everything on the internet was quite grim, and people just weren't talking about this. In 2024, for NMOSD, we have 4 FDA-approved therapies, which is a lot more than 95% of rare diseases. In fact, 95% of rare diseases do not have a single FDA-approved therapy. For MOGAD, we have several clinical trials happening, and I suspect that within the next 3 to 5 years, maybe sooner, we'll have FDA-approved therapies for MOGAD. And then hopefully there's more happening with seronegative patients too. But all this to say that there's been so many breakthroughs in medicine for us patients and in science, and we just understand so much more than we did before, which as a patient I feel very hopeful about that. So I also encourage you all during the breaks to please go out and visit the booths out there. You know, Amgen is here. They have a therapy called Uplizna for NMOSD patients. Alexion is here. They have 2 FDA-approved therapies for NMO called Soliris, and Ultomiris just came out. And then UCB is here. They have an active clinical trial happening for MOGAD, and they're also going to present about the clinical trial today. But please go out there and ask them all the questions, collect the collateral, and do your own research. But there are options for us, which is very luxurious for rare disease patients. So I encourage you to connect with these folks. If you're from industry, can you please raise your hand so folks know who to go to? So that's the UCB team. Amgen is here. Alexion is over there. So they're very nice people. I've known them for many years. They're so friendly. So please go and talk to them and ask them about what options you have. But on that note, you all have been in this field for quite a long time, and you've also seen the evolution of both these diseases. How does that make you feel, and what excites you next in the field?
Well, I think, you know, the biggest challenge to this disease is always going to be identifying the disease. So, you know, once you know you've got this, we have a growing list of incredibly effective drugs that are very safe, very well tolerated, very easy for us as a doctor to administer. And, you know, the insurance industry has really been very welcoming to these drugs, more so than we've seen with a lot of our other therapies. But the trick is getting diagnosed, because when you come to the doctor, you don't initially know you have NMO. You know that you're limping or that your vision is blurry, and you can go through a very long diagnostic journey if you don't start with the right person. You can get passed around, and you know, it can be quite challenging. So, you know, I think from the platform here of people who see it, by the time you get to us, you have probably seen 5 different people. So the real challenge is establishing the diagnosis. And, you know, we haven't talked at all really about MS, but, you know, most people have MS. So you get called MS, and I think increasingly we're realizing that all of our MS patients should be checked for these 2 diseases, because we're going to be wrong a certain percentage of the time. But once you know you have it, these drugs are all so terrific that, you know, it makes us as doctors look really good, because it's pretty rare to have disease breakthrough activity once you get on drug. They're that good. So that is exciting for us.
Dr. Hutto?
So I think a couple of things excite me about the future. And I think the first one, as mostly working in the hospital, the thing that has really excited me in the last couple of years is a growing recognition of how quickly we need to treat people and the therapies that we need to use from the moment patients get to the hospital and the potential that has to actually get people back to where they were. So that is really exciting to me, and we've seen that readily adopted by many of my neurology colleagues and also the folks in transfusion medicine who help us carry out plasmapheresis. But I think one thing in particular that we really need is an FDA-approved treatment for MOGAD, and it has been incredibly exciting. Just as Samara has talked about, there are now 4 FDA-approved treatments for NMO, and I know our MOGAD patients need that as well, and there are 2 active clinical trials, and so I'm especially excited to see what becomes of that in the near future.
Yeah, I think for me, I'm echoing and I agree with what's been said. There's a lot of research in this space too, because I think there's a lot of questions. Why did this happen? Why did this happen to me or my child or my loved one? And, there's a lot of work in that, which is very exciting. But it goes back to what caused this and how do we fix it, the cure. So there's a lot of work in there, which is very exciting. But I think that's what's also really critical and important, which is what is being shown here and the work that the TSF has been doing, is education and increasing awareness. Because I think that's step number 1, that we really need to make sure that all of the medical providers out there, that the lay public is out there, is aware of these diseases, because that they can recognize it. They can recognize it in themselves if they're experiencing those symptoms. And then for the people, the medical professionals who are taking care of those patients, being like, oh, now I know that this exists. These are the tests I need to run. These are the things I need to do. This is how urgently I need to do X, Y, and Z. And so I'm very excited to see this increased awareness and education that's happening in the field.
Dr. Williams?
Okay, my turn. Last but not least, I echo everyone else's sentiments. I think what I would add in addition is that it's a great time to be in the field of neuroimmunology. It's amazing to see people doing well with diseases that were, that still can be very disabling, but it's amazing to see people, continuing to thrive despite these conditions. And I think the thing that I'm excited about, 2 things, is really the patient voice being brought to the forefront. So I'm not a person who lives with, a neuroinflammatory condition, but I remember a time where we would have these meetings and it would just be us. We wouldn't have a patient moderator. That wasn't a thing. You know what I mean? And it's so amazing, this community that you've created, Samira, and just to see, that voice being brought to the forefront, because it's important, right? Whatever treatments, whatever education we do, the patient needs to be at the center, literally, right? Not in a figurative sense, but in a literal sense. And I think the other thing that I'm really excited about is, research focused on brain health. With diseases like MOGAD and NMOSD, before we had, such good treatments available, we were so focused on relapses, and we're still focused on relapses. But now that we know people can do well, we can talk about things like, how do you make your brain healthy? What's the role of exercise? What about diet? What about, holistic health? What about complementary medicine? And so I'm really excited that we now have the space to be able to talk about those things, because we do at least have a better idea of how to treat from the beginning, and we do have treatments that can prevent relapses.
I think we have time for a couple of questions from the audience. Does anyone have a question? Please don't be shy. Yep, we have one right here.
What's the difference between the IVIG and the The difference between the IVIG and the plasma treatment that you were speaking about.
So this is a really, really important question. So there are some major fundamental differences here in that IVIG is essentially a medication that we create through plasma donations. Essentially, we pull together immunoglobulins, package them in a bottle called IVIG, and then we administer it to a patient once a day, usually over the course of 5 days whenever they receive their first treatment, to make sure it's well tolerated. This medication is designed to essentially intercept the bad antibodies and prevent them from causing problems to a patient. Plasmapheresis is different in that it physically removes the pathogenic or the problematic antibody from the patient. So we go in and essentially take out the blood, and then we filter out the antibodies that's inside of a patient's blood, and then take those away, put in new plasma, and give it back to the patient so that it's no longer there. So it's a little bit different in how it's administered. So one is a medication that's given through a standard IV in the patient's arm. The other one actually involves putting in an actual catheter, so that way we can exchange plasma in the person. So it's fairly different logistically in how a patient experiences it. The plasmapheresis occurs once a day for around 3 hours per session, every other day. So it's a little bit more prolonged. The IVIG is something that's infused over a couple of hours, once a day for 5 days in a row. So it's a little bit different. This is a rare disease, so I think we have a lot to learn about what's most effective for the disorders. But I think a lot of people who treat patients with NMO in the hospital setting, in the setting of an acute relapse, probably favor plasmapheresis in this scenario, unless there's some reason why we shouldn't use the machine, essentially. IVIG, there's a lot of data to suggest that it's helpful in preventing relapses, at least. And so some people have adopted that medication in the inpatient setting to help treat acute relapses as well. So there are some kind of fundamental differences there, but there are options that are available to each patient when they're in the hospital.
Your little guy is so cute. How old is he? You are so cute. All right, we have a question right here.
When you speak about the plasmapheresis and the IgG, is there one better than the other to help raise your low IgG numbers? Or what would you recommend?
Well, I just wanted to kind of echo what you said. I've been doing both for 30 years. In my opinion, there's no real comparison. Plasma exchange or plasmapheresis, they're the same, which is very much like kidney dialysis, if anyone has had family members in that situation. It is so fast and so effective, and patients feel terrific much quicker, because you're essentially taking out the toxic antibodies and allowing the body a chance to heal a lot quicker. Now, it does not replete low immunoglobulin levels. So if you have a condition where your IgG levels are low, which is not typically the problem with NMO, IVIG will replace your immunoglobulin levels, but that's probably not the problem for NMO or MOGAD. I think we underutilize plasma exchange because it's very hard to come by. So Emory is in a terrific position. They've got, incredible resources for plasma exchange, but that does not exist in most hospitals in the state. And so what you'll see doctors doing is default to IVIG, because anyone can give IVIG. It's easy, it's readily available, but it's not as quick, and in my opinion, it's not as effective. And so I think we miss an opportunity a lot of times by going to IVIG, and then half the time you end up then going to plasma exchange. And what you do with plasma exchange is you wash out all the IVIG you just spent $100,000 giving the patient. So anyway, but that's kind of the difference. But in terms of low IgG levels, that would be a different issue, and usually more of a consequence of long-term immunosuppressive medication.
All right, I think we have a question over there.
Hi, so you spoke about plasma exchange and IVIG as an onset, treatment as an onset. What about maintenance treatment? Is IVIG still one of the preferences, or is there others?
Yeah, so okay, yeah, so those are treatments that we use primarily for relapses. Now, before we had FDA approved treatments, there were some people who were on regularly scheduled doses of IVIG, but now we pretty much defer to the FDA approved treatments for maintenance, right? So that's if you're having an acute episode, hopefully you can get plasma exchange in the hospital or IVIG, but once that acute episode is over, then we transition to one of those maintenance therapies that are FDA approved.
I'm just going to add my pediatric lens to this because technically the FDA-approved therapies are not for under 18. So we generally will use rituximab more commonly in our NMOSD population. And then for MOGAD, as we sort of talked about earlier, there is no FDA-approved therapy. And so people have tried certain different therapies, including monthly IVIG, rituximab, mycophenolate mofetil, azathioprine, and then tocilizumab, and a few others. And so far, it seems like by far far in terms of, again, mostly retrospective studies, is that IVIG and MOGAD is probably the most effective compared to the others, but it also depends on your resources, right? Because we have a lot of patients who are in resource limited settings where they cannot get IVIG. There's a lot of countries where you can only get IVIG through the black market. And so we have to be mindful of those patients. There are some patients who sort of have that overlap where we're like, oh, you kind of look like MS and you have a low titer MOG antibody. And there's some debate about that. Do you actually have MOG antibody associated disorder or do you actually have MS? And so for those patients, we might consider doing something that can treat both, something like a rituximab or ocrelizumab. But again, it depends on the patient. It depends on what your symptoms are. It depends on how severe your symptoms are and what your recovery is too. We haven't talked a lot about treatment of MOGAD yet, but generally most people will wait till a second attack to choose to start a maintenance treatment in MOG antibody-dissociated disorder, just because it seems to be 50-50, and that has held true even in our experience in over 80 children that we've seen now with MOGAD. But it's really hard because if your first attack was really severe, or you didn't recover very well, it's hard to say, oh, I'm not going to put you on a maintenance without having a second attack. So my practice has been, if you have a severe attack or you don't recover very well, I'm going to go ahead and start you on maintenance. After your first attack, if you recover pretty well, then we'll wait till the second one. And I do have some patients, including here, who have been in that boat too. But that goes back to the research. We need better measures of, can this predict you're going to have a relapse? So I don't have to wait for you to have a second attack to start the treatment.
I'm told we're over time, but that means it was a good session. We are going to take that one last question in the back, but before we do that, our lovely doctors are here with us all day, so by all means, during lunch, during the breaks, go bother them. Or you're just kidding, you're not bothering them. Go ahead and ask them questions during those times too. They would love to answer them. That's why they're here today. So we'll just take that one last question in the back, and then we'll move to the next session.
Okay, so this question is for pseudo relapses. I know we experience pseudo relapses when we get hot or we have an infection or whatever it is. Is it possible to also experience pseudo relapses when we have like a major surgery or something like that?
Yeah, so I think anything that stresses the body systemically can lead to a person experiencing a pseudo relapse. And just so everybody knows, maybe you haven't heard that term before, and I know we touched on it briefly here today. Maybe you've also heard it described as recrudescence. Those are kind of along the same lines. And so what we mean by that is a patient will experience symptoms that they have had before. And I think the critical element there is that it's symptoms that you have had before. If you have new symptoms, then it doesn't make sense for a pseudo-relapse or recrudescence because that's distinctly new, and that probably means that there is a new attack in a different area that you didn't have previously. But pseudo-relapses are your old symptoms coming back in the way that you previously experienced them. So there's nothing new about it that you haven't experienced. But anything that stresses the body can do this. And so we've seen that sometimes in the setting, like in the perioperative setting, if people get overheated, if their electrolytes are off, if they have an infection of any variety. So urinary tract infections are common, especially in people who have had prior attacks involving the spinal cord that make it difficult to urinate normally. But also we see it in patients who have COVID, because COVID's going around, and some of you may have also experienced that too. But bloodstream infections are any variety of things, and so it's common in a host of settings. But importantly for you to know is that it has to be symptoms that you've had before, and you should get worried if symptoms are new. You should be checked out either way, just to be clear. But
is there anything that could be done to prevent? If you knew that flavor, something that could be done prior to that surgery to prevent the possibility of a relapse or pseudo relapse?
This is a very good question. I think the critical piece is that all of the doctors are aware that you have one of these disorders and that it is a possibility and that they involve neurology should you experience that. We don't have a way necessarily to prevent this in the perioperative setting. There are some other neuroinflammatory disorders where sometimes you can kind of, pre-treat somebody and reduce that possibility. So I'm thinking about myasthenia gravis, mainly when I say that. But we don't quite have, or that's not been studied at least. Now that you ask the question, it's kind of getting my mind thinking a little bit about, what can you do to prevent patients from experiencing that? And I think that's the real joy of doing things like this because, I got really nervous when Samira invited me because it's like we're the experts, but you all have been living with this disorder for so long and you're the real experts. And so it's nice to exchange the information and to learn from you. But that's not something that we have routinely done. So in other words, I just think it's really important that the team, especially the surgeons, are aware of what you have and have a little bit of understanding of what it is and who to call should any issues arise. And it's nice to be in a place where they have a neurology team because, like Dr. Stuart talked about, sometimes facilities have varying levels of resources, and so they may not have an inpatient neurologist, and in many hospitals they don't. And so you may also kind of factor that in as you decide where you're going to have the surgery or something of that nature.
And can I just add one quick thing? Certainly it's a possibility, but many people go through surgical procedures and don't have any issues, right? Also, the fact that surgical procedures have gotten a lot less messy, meaning, they have robotics, like things are done remotely. They don't cut you from here to here that much anymore. And so because many surgical procedures are often less invasive, we don't see as many people having prolonged recovery and having, big pseudo relapses associated with surgical procedures as we used to.
Well, thank you to this lovely panel of specialists for joining us on a Sunday. Your insights have been incredibly invaluable. Please join me in giving them a round of applause. Oh, wait, Mitzi, please, we're going to take her.
I know, it's like, I so enjoyed that unicorn. Yeah. That made my day, the youngest member, I get the guy. That made my day.